GI physiology, GI regulatory substances. All right, so first we have gastrin. So gastrin can be released by the G cells, which is located at the antrum of the stomach. What gastrin does is that it signals to our parietal cells to produce gastric acid, gastric H+. So it's going to increase gastric H+ secretion into the lumen of the stomach. It also does increasing in gastric emptying. That's another action of gastrin. But overall, kind of the main thing you want to take away from gastrin is that it increases gastric H+ secretion by essentially signaling to the parietal cells to produce it. Now, what you need to know about this is that gastrin is going to be increased in patients who are on chronic PPI usage. Because if you think about it, if you're taking chronic PPIs, it's going to inhibit the H+ production, right? And so you don't have the acidity in the lumen of the stomach to cause a negative feedback system on gastrin. So without the negative feedback system on gastrin, then gastrin is just going to continue to be producing, and it's going to be wondering, where is my gastric acid? Okay, so that's why gastrin's increased in chronic PPI usage. Same goes for its increase in like atrophic gastritis from H. pylori, for example. Same thing, right? If you're not producing H+, because those cells are being like murdered, those cells are being killed by H. pylori, you're going to have no negative feedback, and so the gastric cells are going to, or the G cells are just going to continue to produce gastrin. It's severely elevated in Zollinger-Ellison syndrome because it's essentially a gastrinoma. It's like just proliferation of these G cells that continuously produce gastrin. We already discussed Zollinger-Ellison back in endocrine, so if you need a refresher there, go back to the endocrine system. Lastly, gastrin is going to be increased in pernicious anemia, okay? So within pernicious anemia, we'll talk about the pathology a little later, but just kind of the footnotes of it is pernicious anemia is parietal cell destruction. Okay, so when we have destruction of parietal cells, that means we cannot produce gastric acid. So same thing there. Without production of gastric acid, you can't have a negative feedback mechanism to decrease gastrin. So gastrin is just going to kind of go haywire and have increased levels in pernicious anemia. All right. Next is going to be somatostatin. Somatostatin we call somatostasis. Okay, the reason behind that is because it pretty much is an inhibitory molecule for all things. Okay, for all hormones. So somatostatin is produced by the D cells. It's the main inhibitor of our GI tract. It decreases gastric acid and pepsinogen secretion. It decreases pancreatic and small intestine fluid secretion. It decreases gallbladder contraction. It decreases insulin and glucagon release. Everything's decreased. Remember, don't memorize it. Just know that it decreases everything, right? Now, it's going to be released in response to increased acid. Okay, so you're going to have more somatostatin when it senses acid. The reason behind that is because when there's acid present, that means that your GI tract is moving forward and you're emptying a lot of the gastric contents, which incorporates acid, right, which includes acid, into your small intestine. And so somatostatin is going to sense that, the D cells are going to sense that, and it's going to want to produce somatostatin to slow everything down, okay? So once again, the main thing is it's going to inhibit secretion of various hormones. Now, we could give a medication, which is just essentially an analog of somatostatin, known as octreotide, okay? Octreotide is helpful in treating acromegaly, carcinoid syndrome, VIPomas, and varicose bleeding. So if you have esophageal varices, you could also give them octreotide, which is just a somatostatin analog, all right? So keep that in the back of your mind. It's very high yield. We'll talk about it in pharmacology, but that's something that they want you to know. Somatostatin has an analog that we can provide and prescribe to patients, and it's octreotide. Next is going to be CCK. CCK is released by the eye cells, and it's going to increase pancreatic secretion and increase gallbladder contraction. So that's kind of its main mechanism of CCK, is to essentially just cause contraction at the pancreas and gallbladder to secrete all of its enzymes out into the duodenum. Pretty much that's all you really need to know about CCK. Next is secretin. Secretin is produced by S cells in the duodenum. This is going to be specifically increasing pancreatic bicarb secretion. You have to know that. Secretin is going to increase pancreatic bicarb secretion, okay? So that we can help neutralize some of the acid that's coming from the stomach, okay? It's also going to decrease gastric acid secretion. But what happens is that increased gastrin only when patient has a gastrinoma. So I just said that it decreases gastric acid secretion, but in patients that have gastrinomas, like Zollinger-Ellison syndrome, you're actually going to see an increase in gastrin only when patients have a gastrinoma. So you could do a secretin releasing test in order to see if the patient actually has some type of Zollinger-Ellison syndrome. All right? Does that make sense to everybody? So normally secretin will decrease gastric acid secretion, but in times of a gastrinoma, you'll see secretin increase gastrin, and it's just like a positive feedback loop that just keeps on getting worse and worse and worse. Higher levels of secretin lead to increased levels of gastrin, and then vice versa. So that's what you're going to be seeing in kind of gastrinomas or Zollinger-Ellison syndrome, which is high yield, okay? And so that's why they do a secretin test in patients that they suspect have Zollinger-Ellison syndrome, all right? I hope that makes logical sense. But take into account the action of secretin as well is to increase pancreatic bicarb secretion. Okay, it wants to increase the pH. It does not want an acidic pH in the duodenum. It wants to kind of neutralize that pH in the duodenum. All right. Moving on, we have the GIPs, the glucose-dependent insulinotropic peptide. Okay, GIP and GLP, essentially the same thing. Now, all these do, they're incretins is what they're called. All these do are going to increase insulin release after taking in oral glucose. Okay, so what happens is if you give a patient oral glucose, their insulin load is going to be way higher compared to if you give them IV glucose. Okay, the reason behind that is because of our GLPs or GIPs. Okay, so GIPs and GLPs play a critical role in spiking your insulin after taking oral glucose compared to IV glucose. Okay, they want you to know that. And there's medications that kind of curb these. And we'll talk about that later on, but just keep that in the back of your mind. They're produced by K cells. Next is motilin. Motilin is just producing the migratory or migrating motor complexes. All that it does is just kind of pushes all the food forward. So we can give patients that have some type of constipation a motilin receptor agonist, which is known as erythromycin. So it's odd, it's an antibiotic, but it also is a motilin receptor agonist. Okay, so it will push it forward. So it's used to stimulate intestinal peristalsis, which just means it pushes the food forward. All right. Next is VIP. So VIP is important with its high yield association to VIPoma. Okay, so VIPoma, what you're going to be expecting in this patient, it's going to be around a patient that's aged 30 to 50, okay? 30 to 50-year-old patient with long-standing watery diarrhea. Watery diarrhea is very high yield, okay? And the watery diarrhea, because they're constantly having watery diarrhea, they could potentially have an electrolyte abnormality of hypokalemia, okay? So they'll have hypokalemia because they're losing all of the potassium out into the diarrhea. There's no response to diet control. So the patients are like, I've changed my diet multiple times. The watery diarrhea is still there. Okay, so that's huge for VIPoma. And then they test the stools, and the pH of the stool is going to be elevated. It's going to be alkalotic, okay? Alkalotic. Increased pH in the stools and in the stomach, okay? So that's very, very key. The reason you have increased pH in the stomach is because it also causes achlorhydria, all right? And the main acid in your stomach is HCl, right? So you have increased pH in the stomach because of achlorhydria, all right? And the diarrhea is usually T-color and odorless. Okay, so that's the last thing you have to take away for VIPomas. They like to present it a lot of the time, but the normal mechanism of action for VIP is to just increase intestinal water and electrolyte secretion. So obviously, if you have too much VIP, that's why you're going to see these symptoms present in these patients, okay? So you treat a VIPoma with somatostatin. Can you guess why? Exactly. It's the main inhibitor of the system, somatostatin, right? Or you could give them like octreotide, right? Is our analog for somatostatin. And that will help decrease VIP, right? So remember, it's associated with watery diarrhea, hypokalemia, and sorry, this is like the worst word in the world, but essentially there's like not a lot of chloride within the GI tract in the stool. All right. Next is nitric oxide. Not much here. You know that it's just like a smooth muscle relaxant. Okay. So it relaxes all the sphincters. Next is going to be ghrelin. Ghrelin is going to make you hungry. Okay. It's going to be increased in Prader-Willi syndrome. All right. Moving forward, we have gastric acid. Remember, gastric acid is going to be released by mainly the parietal cells in order to decrease the stomach pH. Okay. It's going to be released in response to increased gastrin, right? So gastrin is going to kind of act on the parietal cells to release gastric acid. Okay. And it also can be released and increased by histamine, vagal stimulation as well. Okay, and we'll talk about kind of the regulation of gastric acid on the next page. But for right now, that's really all I need to know, all I want you to know for kind of the time being. Another thing that's released by the parietal cells, not only gastric acid, but also intrinsic factor. Intrinsic factor is key for helping kind of absorb vitamin B12. Okay, and we'll talk about that vitamin B12 process. It's very straightforward. So one of the main pathologies associated with this is autoimmune destruction of parietal cells. We already discussed pernicious anemia, right? So that can cause increased levels of gastrin, right? And then an overall decreased level of gastric acid and intrinsic factor because that's what's produced by the parietal cells. Pepsin is produced by chief cells. This is going to be released and increased by vagal stimulation, acetylcholine. And pepsinogen is the inactive form. It's converted to pepsin in the presence of H+, in the presence of acid. Lastly, what I want you to know is kind of take a look at the histology and the photos, diagrams of where each cell type is located when looking at like the stomach, okay? Because they want you to know where the parietal cells are located. Keep in mind, like where, like for example, you could see like a gastric pit, okay? What's located in the gastric pit? you have the surface epithelium, right? And then they kind of break it down further. You can see where the parietal cells are. Look where the chief cells are. The chief cells are located lower, okay? Where the parietal cells are located kind of in the upper glandular layer, okay? The chief cells are going to be located in the deeper glandular layer, right? So keep in mind those kind of three layers. Once again, not too high yield, but I remember it being honestly in either the CBSE or one of the higher yield exams, like one of the crazier exams. I remember this being a question. I forget the specific question, but I remember them like maybe potentially showing me a diagram themselves that they drew and asking where one of the cell types of the stomach was located. The parietal cell, the chief cell, that's what they were asking about, okay? Once again, I wouldn't worry too much about this physiology chapter. It's not too crazy high yield, but once again, it helps lay the groundwork for what happens when situations go bad for the pathology. What I would recommend you know is the gastrin. Gastrin is very important, and it's with like gastric acid and intrinsic factor, those three. And then somatostatin, very important, and secretin is very important. The last one I would probably discuss, highest yield would be VIP from the VIP almost. All right, so those are the key takeaway ones, and we'll discuss what goes on with the acid production in the next video.